This video is going to illustrate the setup of the pelvic reduction frame. The patient is placed supine. We typically use an OSI Mizuno flat top table. The frame is essentially two wagon wheels or semicircles, and the sides of the frame attached to the table using clamps. The clamps are specially designed to fit the profile of the OSI flat top table. We basically center the frames over the pelvis. The inner ring should be more or less level with the greater trochanter on each side. A little bit high, a little bit low, doesn't seem to matter. Usually your position is dictated by the arm boards on the patient, but in this case, the cadaver didn't have any arms, so the frame can go anywhere. Once the frame is attached on each side, you stabilize it by placing a long carbon fiber bar connecting the two sides. As you place the bar, it's helpful to push the frame in from each side a little bit. This gives it a little bit of tension and increases the rigidity of the frame a little bit, makes it a little bit more stable, a little bit more rigid. Once the frame wheels are attached to the table, now it's time to stabilize the patient to the frame. Typically, you'll stabilize the least injured side to the frame. We almost always use two pins to do this. We use one pin down the LC2 corridor and another pin that's placed transversely from lateral to medial above the acetabulum. We're going to show you both of these pins. In the video here, the first one that's going to be placed is the LC2 pin. You have to find a TP view first to demonstrate the LC2 corridor, and then you roll over to an iliac oblique view and place the pin starting at the anterior inferior iliac spine, and you want to aim back above the greater sciatic notch. Once the guide wire is started, then you roll over to a down the wing view, and that helps you keep the pin inside the ilium. You don't want to go too far medial or too far lateral. It helps to use a wet lap to get a better grab on the pin as you put it in so you don't slip off medial or lateral. As the pin is placed, the surgeon flips between an iliac oblique and a down the wing view to make sure that the pin is placed in the right spot. Once the pin is correctly placed, we attach it to the frame using another long bar. Typically, this will be hooked onto the crossbar that you put on just a minute ago. You want to try to get this crossbar as close to the body as you can because that makes the frame more rigid. Now that the LC2 pin has been placed, the next pin is a lateral to medial pin placed just above the acetabulum. Typically, we use a 6 millimeter wide pin for this. It gives a little bit more stability. Again, a wet lap is useful to hold the pin in place while you're driving it in. You start off on the AP view, and usually you can feel as the pin goes through the medial cortex. An obturator oblique view is also useful to demonstrate the tip of the pin piercing the medial cortex. In this case, the pin is a little bit high. I would have preferred to have it a little bit lower, but it'll work fine. Once the pin is in place, usually you hook a bar vertically onto the inner ring of the wagon wheel of the frame, and then use two bar-to-bar clamps to hook that bar onto the ring of the frame, and then a pin-to-bar clamp holds the pin in place. The 6 millimeter pins are extra long, and so almost always there's an extra length of pin that's in the way. You have to cut this to make sure that it doesn't interfere with the position of the C-arm as it swings around. Now the patient is anchored to the frame, and you can start your reduction of the injury on the right side. The frame has tools that are intended to allow percutaneous pushing, pulling, dragging. In addition to skeletal traction through the OSI table, we also use tools like the Kugelspitz being demonstrated here. The Kugelspitz attachment can piston in and out of the motor that's being attached to the frame. The knurl knobs on the threaded bar on the motor allow you to gradually push in on the bone and achieve a steady, slow, and steady correction. Typically, it's better if the surgeon does this with his body. The blue towel shown here prevents the motor from ripping through the surgeon's paper gown. And as you push in, the assistant can catch up and hold on to the reduction achieved by using the knurl knob.